A very good day, my dear postgraduate students. The title on the screen is Giant Cell Lesions of the Bone, and it is a SNP topic, short notes and pathology. But then, please be careful and discover the number of questions we are going to unravel or the number of slides that will be challenging us. This is a beautiful schematic table which we should know. Always the bone lesions are based on the age, whether they are sclerotic or lytic, whether they are well defined or ill defined, and their location thereof. So, this is something that I would like you people to go through repeatedly. I am not going to read the list. And please do remember, age matters most. And there are too many questions for us to answer. This is a rather more sensible table which you shall by heart and write in the exam. The tumors can be divided into the reactive, benign, and the malignant, rather the lesions. So some of them are non-neoplastic, as the brown tumor, the giant cell reparative granuloma. Others can be benign, the giant cell tumor, malignant, and osteosarcoma. Chondroblastoma also comes somewhere in between. And there are others which may not be connected to the bone proper, but can be found in it. So these are certain things that you should be having in mind. Let us go to the topic as such. Too many to diagnose. So this is a fundamental undergraduate specimen and a slide which we all like. But then this person, Jaffe, an authority in orthopedic pathology. So it was called the giant cell tumor. The osteoclastoma is supposed to be a misnomer. In this, I am finding there is a expansive lesion at the lower end of the bone, and then I find that the cortex is intact. There is a large nidus of the tumor which is filled with hemorrhagic material, and there are septae which could be seen in between. So that is being reflected in these radiographs. So I'm able to see the bony septae, and in between there are the clear spaces and a thin rim of cortex which is surrounding it, and there is no invasion into the joint space. Epiphysis, but then sesamoid bones can also be involved. Radiologically, you have got the classical soap bubble appearance. Histologically, I find that there will be the mononuclear cells. Look at the small plasma cell-like cells. They can be round or ovoid, but then they are all being punctuated at regular intervals. Look at this word, at regular intervals by multinucleated giant cells resembling the osteoclast. So more than 50 nuclei may be seen. And the malignancy itself can be based on the mitosis or increased atypia or a decrease in the number of giant cells. Metastasis is very rare, but local recurrence is known for it. And the detection can be used by means of these genes. So please remember G34W mutation of the H3F3A gene. So this is important because to do away with the others also we need this. Now, close on the heels of the giant cell tumor of the bone, I have got another lesion called the brown tumor of parathyroid. In fact, there has been many an instance where either of them have been misdiagnosed one for the other. Also called the osteitis fibrosa cystica, it is a non-neoplastic disorder and associated with severe hyperparathyroidism. And radiologically here also it is an expansile. There can be a soap bubble appearance. But importance will be hemosiderin-laden macrophages can be there. And secondly, you find that it is multicentric. Third, you find that with the treatment of the hyperparathyroidism, the lesion can resolve. Look at this beautiful picture again. I think probably it is a rib or so. in which I am finding a classical soap bubble appearance and the hemorrhage can be very easily appreciated. And it can be found in these bones also, the maxilla in this case or the mandible. And I find that there are other lesions which should be differentiated. Hence, a clinical history is mandatory. So, multifocal giant cell tumors are rare. Therefore, if it is multifocal, it has to be either metastatic or a brown tumor, and hence parathormone is important. The surgical treatment for the GCT is curettage and cementing. Frankel inhibitors can be used. This is another friend of ours, the undergraduate question, the osteogenic sarcoma. So in which you find that there is a giant cell rich osteosarcoma that has been taken as an example, where there can be pleomorphism. In fact, the key word for the diagnosis of an osteosarcoma will be atypia, angry looking, hemorrhage and necrosis, as you see in a cross picture. And there can be three types of differentiations: fibroblastic, chondrogenic, or osteogenic differentiation. And one thing is the tumor can be in the first or the second decades or after the fourth decade in the case of a secondary osteosarcoma as in Paget's or even osteomalacia at all ages. The giant cells here are much smaller, fewer nuclei, and they will be localized in one region. And more important will be, I'll be finding the tumor cells which are laying down the osteoid tissue. And here it is important because I do not see the osteocytes, only the peripherally the bone laying cells are seen. So osteosarcoma important, and there can be a friend of ours, the Codman's triangle, which, however, is not classical of osteogenic sarcoma. So this is somewhere between the metaphysis and the diaphysis wherein you can get. So also an Ewing sarcoma can occur in these regions. Osteomyelitis, surprisingly, aneurysmal bone cyst, giant cell tumor, metastasis, juxtacortical chondrosarcoma, MFH are all conditions where we can get a Codman's triangle. So Codman's triangle is not diagnostic but is significant in osteogenic sarcoma. So this also we should be knowing. What is the rough age? So extremely important, which the clinicians will not be giving us. I would like you people to kindly leisurely go through it and then make an answer. Is it clear? For example, 30 years and above, I should be thinking of a giant cell tube. And whereas if it is going to be younger, there can be an osteogenic sarcoma, as in this case. And this is for your eyes only. Osteoblastoma. A typical history will be a very painful lesion. Not much, slowly expanding lesion, but highly painful. A benign bone-forming tumor, it forms just about 1%. And these are the common bones, the sacrum or the spine. And what is important will be clinical, radiological, and histopathological examinations. It is an indolent tumor but can be aggressive in some cases. So it has to be distinguished from other tumors such as the osteoblastoma. So these are the references. And look at this lesion over here. This is a marrow proper, and I find that there is a nidus of a lesion which is being surrounded by a more sclerotic bone. The microscopic appearance will be, there can be the osteoid osteoma, osteoblastoma, which are more or less similar. Here I am finding a mosaic-like pattern. That means there is a laying down of the new bone on the top of the membranous bone. But what is important will be, there will be a nidus which is hemorrhagic and some amount of necrosis, something like an abscess, which is highly painful. And the size can vary. Usually it is about 1 to 2 centimeters. Whereas in the others, there won't be a nidus that can be seen. Please remember this mnemonic, Pico-Nomasic. I do not know what it is, but it is a splendid mnemonic that you people can remember. So these are all the giant cell lesions. fibrous dysplasia, eosinophilic granuloma, giant cell tumor. Then NOF, what is it? Osteoblastoma, metastasis, aneurysmal bone cyst, solitary bone cyst, hyperparathyroidism, infection, chondroblastoma, etc. NOF can be a non-ossifying fibrome. So aneurysmal bone cyst. Usually I find that there is a spindle-shaped lesion. There is a thinning of the bone and patient can come with a fracture or it can be an incidental finding, an expansive lesion that is seen, and obviously there will be areas of hemorrhage because there is a term called as aneurysm. Therefore, distended blood vessels shall and will be seen. It can be mistaken for giant cell tumor, but then even if there can be such a secondary changes, please do remember. So it can occur in the metaphysis or in the epiphysis and negative for this expression. That is why the bone tumors are important. And can you describe this? I find that there is a large cystic space which is walled by fibrocollagenous and sometimes a muscular tissue. There can be an endothelial lining or not, but I do find it is being covered with multiple giant cells, osteoclast-like giant cells, and the expansive lesion, thinning of the cortex that is seen. The non-ossifying fibroma. Again, it can cause a metaphyseal defect in the long bones. The fibrous tissue is virtually replacing the bone in skeletally immature patients. Plump, spindle-shaped cells. And I do see this osteoclast-like giant cells. Negative for this HG34W. And look at the lesion, a cystic lesion of the bone. Thanks to pathology outlines. This is a typical picture that we had seen in a case of a giant cell tumor. But if no history is given, you cannot distinguish between the giant cell tumor and the brown tumor of the parathyroid. So it will be of paramount importance to get the clinical finding, the radiological finding, and the specimen as such, as well as the histological slide. So these are the sources for reference. Please go to Jaffe, please go to Ackerman, please go to the other references that I have quoted. A more sensible mnemonic, this I had already mentioned. Is it clear? Fog machines is another one. So fibrous dysplasia, osteoblastoma, giant cell tumor, metastasis, ABC, chondroblastoma, brown tumor, infection, ossifying fibroma, enchondroma, and simple bone cyst or the unicameral bone cyst. A fantastic list for you people to reproduce. And what is it? I'm finding something over here. The diagnosis wherein you'll be finding multiple giant cells as these, along with areas of hemorrhage. So this can be a giant cell reparative granuloma or an epithelium that is found in the maxillary bone, etc. Mononuclear stromal cells are absent in this, but I find a lot of these giant cells. Metastasis is rare, and usually you don't get a giant cell tumor of the bone at these sites. Another differential diagnosis can be the fibrohistiocytic reaction or a non-ossifying fibrome. The giant cell epithelium, this is how it appears. Again, there can be a central hemorrhagic nidus surrounded by a more hard or a sclerotic bone. And that is exactly what this radiology depicts. There can be ulceration of the overlying, and sometimes there can be increased mitotic figures. Giant cell tumor of the tendon sheath, an exam slide for us. Almost similar, but one thing, you find that the giant cells will not be uniformly distributed. They can be scattered. And the second point is there can be the hemosiderin-laden macrophages. Pigmented villonodular synovitis is supposed to be a misnomer for us. There are two types, the localized and the diffuse, a classical clinical picture, but then the diffuse can be more brown, yellowish, spongy, and there can be malignancy occurring in it. So these are the localized and the diffuse types. Kindly go through them. And I find that there can be aggregates of histiocyte-like cells in a case of this. So multinucleated giant cells, foamy macrophages, hemosiderin, pigmentation, mitosis can be increased. And of course, the xanthoma cells, cholesterol, clefts, and hemosiderin pigment. This is again the same over here. But look at the differential diagnosis. Just like the Codman's triangle, I have got a list of differentials. The ganglion is the cystic component of it, and then the pigmented villonodular synovitis. Histologically identical to this one. Desmoid tumor, fibroma and fibrosarcoma, glomangioma, glomus tumor, exactly subungual in location, painful. The chondroblastoma, the last friend of ours, you find that there is. What I can appreciate is the chondroid matrix in these regions. I should be extremely careful because a chondrogenic differentiation can be seen in an osteosarcoma also. But what is important will be the tumor cells will have to lay down the tumor osteoid. Bone will have to be seen in the case of osteosarcoma. That having been said, I'll be finding the chondrocytes in pairs or in fours, and they will be atypical. Look at this area of chondroid differentiation, and they are again well circumscribed, can be occurring in the long or the flat bones. Thank you.